to announce the next Endowment Award, the Dr. P. Namperumalsamy Endowment Award. I feel proud and privileged because I did my fellowship from Arvind, and sir has always been a mentor. So Dr. P. Namperumalsamy is one of the founding member of the Arvind Eye Care System and is currently its chairman emeritus and professor of ophthalmology. He started his career at Government Rajaji Hospital in Madurai. He started Vitreoretinal Surgery Center at Government Rajaji Hospital, Madurai, first of its kind in India, and then Retinovitre's Clinic at Arvind Eye Hospital in 1979. Dr. Namperumalsamy established Center of Relevance and Excellence in Diabetic Retinopathy in association with Government of India, World Diabetes Foundation, Denmark and Topcon. He has received Padma Shri Award by the Government of India, Lifetime Achievement Award by All India Ophthalmological Society and Tamil Nadu Ophthalmological Association. In 2010, Time magazine listed him as one among the 100 most influential people in the world. So I feel proud and privileged to be his student and be on this platform to introduce Dr. Lalit Verma sir for the Dr. P. Namperumalsamy Award. Can I have the next slide, please? Audio visual, the slides are not moving. Yeah, so it's my proud privilege to introduce mentor, the guidance given by Dr. Lalit Verma sir to all of us in AIOS. So Dr. Lalit Verma sir is the immediate past president of AIOS in 2022-23. He was the Secretary General. He is the Secretary General of South Asian Academy of Ophthalmology. He is Director of Vitreoretinal Services at Center for Sight, New Delhi. He did his MBBS and MD from AIMS, New Delhi, Vitreoretinal Fellowship at LSU, USA. He spent 21 years at Dr. R.P. Center, AIMS from 1983 to 2003. He authored the book, A Manual of Fluorescent Angiography, plus a book on intravitreal injections. He's got to his credit CME series of AIOS on endophthalmitis and uveitis. He has written 41 chapters in the book, and we all have the privilege to work under his guidance in the All India Ophthalmological Society. He has dedicated his n number of times and minutes and hours to this society. So I welcome Dr. Lalit Verma sir to give his endowment lecture, the AIS Dr. P. Namperumalsamy Endowment Lecture 2024 with the lecture titled Vitreoretinal Interface Disorders. Over to you, sir.
Thank you, Amit, for this intro. It's really an honor and privilege to stand before this august body and deliver this endowment lecture in the name of someone who is a doyen, who is a legend. NAM, as we know him popularly called NAM, has innumerable contributions in the field of retina. In fact, retina in India would not have been the same had not NAM and Dr. Badrinath and P.N. Nagpal, they would have contributed the same way. So I call him as a living legend. As I said, NAM is a doyen in India and abroad. He is one person who is magnanimous in giving. He is a man of masses. One phone call, I think, once I rang him up, an immediate response came that he will be there. His academic achievements, awards are beyond the comprehension of anybody. Chairman Emeritus of Arvind Eye Care System, the most well-structured system, featured in Time magazine also. Besides all this, he is an excellent human being, and I am very proud to be standing here and delivering an endowment lecture in his name. So topic I have chosen is interface disorders, which is very, very close to my heart and also very commonly seen by all the ophthalmologists and frequently misdiagnosed, mistreated also. So I begin with a slide, this OCT, which all ophthalmologists do nowadays, and all these 10 layers, which is also known as optical biopsy of the retina. On OCT, you can classify pathologies into various categories: inner retina and outer retina. Inner is from ILM, which is here, to ELM, which is here. Outer retina is from ELM to RPE. But I am focusing today on only one aspect, that is interface pathologies, where the vitreous meets the retina. You see, we are all born with 100% gel vitreous. Gel vitreous which is consistency of a white of an egg. And this vitreous is optically clear. And it has attachments of various adhesions in different people. What happens with age and disease, trauma and diabetes? Two things occur. One is vitreous gets liquefied. Second is the adhesion between the vitreous and retina weakens with time. If both the processes, that is liquefaction and adhesion, occur completely, we have a total PVD. And that is the time when you have flashes or floaters may occur. And that is also the time when horseshoe tear formation may occur. But if the liquefaction occurs but adhesion is still there, this allows this liquid vitreous to seep in the retrohyaloid space, and this initiates a PVD. And this is a stimulus for cells to proliferate, and this can be accelerated by breakdown of blood-retinal barrier, by trauma, diabetes, so many things. It is this anomalous PVD, which is not a complete PVD, which is the backbone of all these interface disorders which are enumerated here, whether it be VMT, hole formation, epiretinal membrane. So this is one classification which was given a long time back, but even Gauss, when OCT was not there, he had similarly given this classification. VMA, VMT and various hole formation and lamellar macular hole and pseudo holes. The thing to be noticed here is, in this classification there are small, medium and large. Definition means 250 micron, 400. But believe me, in our clinical practice we get extra large or XXL kind of macular holes which have 1000 and 2000 microns in diameter. So VMA is one pathology. I don't know whether it's a pathology or not, but it's a normal kind of finding where vitreous remains adherent in a broad dumbbell shape, but it is not pulling the retina. Since there is no pull on the retina, there are no symptoms. VMT in contrast is a disease where there is a pull. If you see these pictures here, there is a pull. If there is a pull, then the photoreceptors may get distorted and you may have metamorphopsia. And if it lingers on for some time, you may have macular edema and decreased vision. The key question which all of us face every day, do all this VMT require intervention? The answer is a very big no, because a lot of these patients of VMT have tolerable kind of metamorphopsia or off and on metamorphopsia, and sometimes complete PVD may also occur. I'll just show you two examples of each. This is one lady which we operated long time back, fortunate to have good vision, recovery in a macular hole. Left eye, there is no symptoms at all, but you see the OCT, it's a alarming OCT. So this patient got scared and said, Dr. Sahab, OCT, there is a pull. But believe me, all OCT diagnosed VMTs, we don't operate at all. This is another patient whom we were preparing because this patient had progressed from February 16 to June 16. This pull increased. Patient started complaining of troublesome metamorphopsia, but in between this membrane spontaneously got separated hyaloid, BCVA returned to 6/6 and N6. So there could be spontaneous resolution of VMT also. So management of VMT is only if it is symptomatic. Symptomatic also, patient should be troubled by metamorphopsia in his day-to-day life and virtually begging for surgery that, Dr. Sahab, we can't carry day-to-day work. Or other indications could be decreased vision or cystoid macular edema. Remember, we don't treat the OCT, we treat a human eye which is having some issues. And basic aim in this management is to get rid of this greenish pseudoocular membrane, which is the hyaloid, which is pulling the macula. And all of us vitreous surgeons are experienced with doing MIVS surgery, and the success rate of MIVS is more than 90-95%. In came this injection, more than a decade back, thinking that they will take away the bread and butter of a vitreous surgeon, which is oculoplasmin jetria. Jetria came with a big bang, but disappeared also with a very big bang. Not only it was expensive, but the success rate for dismissal to 27% only. And there was this important study which compared jetria versus vitrectomy. Success rate with jetria 50% and with vitrectomy nearly 100%. So as of today, I think most of us are doing MIVS for this VMT, and it's a relatively smaller surgery. It does not take more than 10-15 minutes. PVD induction is the key step. You see, once we do a core vitrectomy, we inject these tricot crystals. These get adsorbed onto the vitreous, and classically two foci will form, one over the disc and one over the macula, and gradually you increase the suction with the help of this cutter, and always keeping an eye onto the retina that you do not cause any iatrogenesis. So results are pretty rewarding. This is one patient pre and post. Foveal contour may take months and months to come, but the metamorphosia goes away within a couple of days or weeks. This is the second video showing similar thing, but here what point to be noticed is this patient had a huge tenting of the macula. So here we have to be careful that you do not cause too much pull on the macula, lest you induce an iatrogenic macular hole. The only difference between the previous video and this video is here it's a foveal sparing kind of PVD, and we leave this small whitish stump here. Do not pull this, otherwise you can cause an iatrogenic macular hole. So this is the result of this patient where foveal sparing PVD has been done. Result is pretty good, some fluid, but patient is very happy because metamorphopsia has gone. This is another patient who had similar foveal sparing PVD induction. The next membrane which bothers us is in this interval disorder is epiretinal membrane. Epi means upon, epiretinal membrane. These three membranes we deal day in and day out. One is the hyaloid, which I just described. Second is epiretinal membrane. Third is this macular hole, where the culprit is ILM. Here again, all ERMs don't require surgery. This patient has 6/6 vision, so does not require any invasive kind of procedures. Here again, you see MIVS is the treatment of choice, and again does not take much time. It's a very, very rewarding surgery. After you have dealt with the hyaloid phase, I normally will stain this membrane with trypan blue, because trypan blue is very selective for epiretinal membranes. And the key step is to identify the edge. Once the edge is identified, then it's a very simple job that you either persist with this MVR blade, or you take with a card forceps and peel it out. This is another patient who has had dry RMD, MIVS in progress, put tricot to take care of the hyaloid, and once the hyaloid is out, under the air I will inject 2 or 3 drops of trypan blue after I have made it dry, the posterior pole, with the help of this backflash needle. 1 or 2 drops, wait for a minute or so, and remove this excess dye under the air itself. And once this dye has been removed, you see a nicely stained epiretinal membrane here. And then comes this instrument to create an edge, because this is the critical step, is create an edge. And this is a MVR blade, which is an old MVR blade, because an old MVR blade will have a small bend, and this acts like a micro pick. And then you take this membrane out in a single sheet. And after that, normally we don't inject gas also, we just do an airflow exchange and come out of it. This is the result of this patient. Most of these macular surgeries, if there is a early cataract, we tend to remove at the same sitting, because cataract can increase after this vitreous surgery. Role of ILM peel, because all of us retina surgeons are ILM addicts. They want to take out ILM in all patients, irrespective. But believe me, in a pure ERM, peeling of ILM is not necessary. We do try to take it out just to have assurance that all membranes in front have been taken out, and it has a theoretical advantage of decreasing the post-op ERM formation. The third, the last thing which I want to cover is about the hole. The whole surgery has evolved from the day we were residents to this present stage, when virtually all macular holes are at least closable. We can close. This is a diamond dusted instrument, but as of now we do a pinch and peel technique, And this surgery shows how ILM peeling is done, where the ILM, after being, plane is created, you take it across the macular hole, and in the first sitting we try to peel this ILM as wide as possible. Couple of hemorrhages may occur, but that do not affect. This is the post-op result, and believe me, this result is obtainable in a lot of patients of macular hole, provided the height is more and the base is less. Another patient showing type 1 kind of closure in a macular hole. A lot of things have happened in macular surgery, the choice of tamponade, the duration of tamponade. Nowadays, in fact, OCT has made us wiser that positioning is hardly required. You see, one day position, or even in a obese lady, you just tilting of the head for a day or so does the job. And a lot of other materials like ILM transplant, retinal transplant, or lens tissue remnants are also being used. I'll just skip this video because it does not have much. So game changer for me was 2016 when I attended this AIOS conference, when we learnt about the ILM flap procedure. And this was my first flap patient after I came back from the conference. This lady was under my follow-up for more than 10 years. She had a large hole, 1400 microns. I offered her this surgery, and the difference between the peel and the flap is that you don't take it across the macular hole. You just leave this flap at the edge of the macular hole, and you go across and across. There are various modifications. Then some people will have a mini flap, or some people will have only temporal flap. But this is the flap which have been created, and after that the rest of the ILM can be peeled away, and at the end, at the lowest possible suction and the maximum possible cut rate, you trim this flap, and then you inject gas inside. This was the result. You see 1407, and this was the closure I achieved. And since that day onwards, I have shifted to flap making surgery in macular hole in a lot of these patients of chronic macular hole or very large macular hole. So world is today divided between peelers and non-peelers, and the indications of flap surgery primarily are XX kind of macular hole, large macular hole, chronic macular hole, or reopened macular hole, or myopic macular hole. So this is just a pictorial demonstration that as the height decreases, the basal diameter of the macular hole increases. So these patients where the basal diameter is more than the height, I think they are the right candidates for flap surgery. Other things like retinal transplant or ILM transplant also can be tried in these patients. So this is the close classification wherein people actually have now said extra large, extra large, and giant kind of macular holes, and these XL and XSL, they respond more to these newer techniques of flap or also human amniotic membrane and autologous retinal transplantation. So thus to conclude, this VR interface disorder is a pretty common kind of disorders, often misdiagnosed or missed unless you do an OCT. And OCT and this newer theory of anomalous PVD helps in better understanding of the interface disorders. And Jetri, as I said, has gone into oblivion as far as I am concerned. And the world, as I said, is divided into peelers and non-peelers. As of today, nobody should be refused surgery in a macular hole, whether the vision improves or not. At least anatomically we can close, and functional results also are pretty good in more than 80% of these patients. And the staining agents actually have added specificity because the visualization actually improves with this stone. Thank you very much for your kind attention, and thank you Scientific Committee and AIOS for this honor.
Thank you, Lalit sir.